right, this is Candy, and we are ready to begin.
Okay, great. Just a moment, please. I'll get you merged in.
Absolutely.
So this, yeah, fine. Okay. Can I advance the page down?
You would advance on this one.
Good afternoon, ladies and gentlemen, and thank you for waiting. Welcome to the Stratus Health conference call, overview of the final rule for stages 1 through 3. All lines have been placed on listen-only mode, and the floor will be open for your questions later in the call. Without further ado, it is my pleasure to turn the floor over to your host, Ms. Candy Hansen. Candy, the floor is yours.
Thank you, and welcome everybody to our Lake Superior Quality Innovation Network webinar, the first in a two-part series on the changes to meaningful use based on the final rule. Our speaker today is Dr. Paul Kleeberg. Dr. Kleeberg has played key roles in EHR implementations in integrated delivery systems and is passionate about leveraging health information technology to improve care. Dr. Kleeberg is the Chief Medical Informatics Officer for Stratus Health in Minnesota and the Clinical Director for the Regional Extension Center for HIT for Minnesota and North Dakota. Dr. Kleeberg also serves as our National Coordinating Center Team's Health Information Technology expert. Before I turn the floor over to Dr. Kleeberg, I wanted to make everyone aware of a change in the date for next week's webinar, the second in the series. Due to circumstances beyond our control, we had to change the date from Monday, 10/26, to Wednesday, 10/28, and it will be held at the same time. And if you've already registered, you don't need to do anything different. Dr. Kleeberg?
Thank you, Candy. Maybe the organizer here and I'll get started. So today's webinar is really a high-level overview of meaningful use stages 1 through 3 final rule that came out as final rule with comments. And I would like to be able to go through it rather quickly today and leave some time for questions at the questions, period. I know many of you folks out there sometimes are afraid to ask questions because you don't want to appear dumb and all those other things. So what I would suggest you do is send your questions directly to the host and, let's see what it is in the drop-down. All panelists, that would be safe. Send it to all panelists, and only us that are providing the webinar will be able to see it. So we'll answer those questions as we are able or at the end. So let's get started. Again, like I mentioned, we're going to provide you with an overview, and we're really just doing it for 2015 through 2018. One of the reasons why we're not including 2019 is because MACRA came out after this rule was first published as a proposed rule, and it really changes things after 2019 and later. So as I mentioned, we'd like to have some time for discussion and questions at the end. This is brought to you by the Lake Superior Quality Innovation Network. We are 3 quality improvement organizations, MPRO in Michigan, Stratus Health in Minnesota, and Metastar in Wisconsin. And together, we collaborate to improve health care for Medicare consumers. We share best practices, maximize efficiencies, and provide support to you out there so that you can actually provide the best care possible. So the evolution of the rule, oops. Okay, I didn't realize that these are, here we go, good. As you know, the proposed rule for stage 3 came out in March 30th. The proposed rule for 1 and 2 came out on April 15th. And as I mentioned, the Medicare Access and Chip Reauthorization Act, also known as MACRA, came out on April 6th, or was signed by the President on April 16th, the day after the proposed rule came out. And it modifies what's happening after starting in 2019. You'll notice that this final rule has a comment period. Now that's confused a number of people. The comment periods, and I got this straight from Robert Anthony at CMS, that comment period is just a general comment period. It's not going to change anything in stage 1 and 2, and potentially there may be future rulemaking for stage 3 and later. So they would use any comments for potential any later rulemaking. But the rule right now is is final, but they are inviting comments without any specific questions. I did warn them that some people are going to say this stinks, but that they're looking for some specific comments. On that link on this document is a direct link to the HTML version of the final rule. And again, I have found the HTML version very useful to use because you can search it with your web browser and find what you're looking for, but also you can grab a link to exactly the location in the document and send it to someone else when you have found something that answers a question. So the timeline changes. What we have noticed in the proposed rule that came through, 2015 is going to be 90 days. They also proposed 90 days for those who are attempting to do meaningful use in 2017. So that's only if you're doing meaningful use stage 3 in 2017 do you get 90 days. There is a stage 1 for everyone in 2016. It's not a complete stage 1. It's partially stage 2, but there's some exceptions that we'll talk about on the next couple of slides. And in 2017, there are none. So everyone virtually is doing stage 2, regardless of when you start doing meaningful use. And by 2018, again, everyone is on stage 3 for a full year. That's how it's designed. So as you know, the hospitals are changed for a calendar year, and for 2014, it's going to be a 15-month a 15-month potential attestation period. So it starts with October 1, goes through December 31st. In 2015, it can be any 90 days in that year. 2016 and 2017 can be 90 days for first-time attesters. That's new. The proposed rule claimed only 2016, but they included 2017 now as well. And 2018 is going to be a full year. And yes, Medicaid is still an option. AIU is still an option for the first year of participants in 2015 or 2016. And I believe 2016 is the last year you can get incentive for AIU, but again, AIU does not qualify you, does not say you achieve meaningful use, and if you just do AIU, you are subject to the penalties. So there's no change in the attestation methods. Again, the attestation site is closed until January 2016, and everyone will need to attest sometime between that when it opens in January and the end of February of 2016, and for all of the years, the last day in February of every year. Medicaid providers who fall below 30% or pediatricians below 20% will be able to attest without switching programs. Would we be able to get a copy of this PowerPoint? Yes. The PowerPoint will be available within a few days after this presentation is done. Penalties and exemptions really are unchanged for anyone attesting for the first time before February 2016, and they won't be penalized in either 2016 or 2017. Now, for all those who attest for the first time by October 1st, 2016, they won't be penalized in 2017 or 2018. This is the way it was in the proposed rule, but that will now also apply to 2017, since for your first-time attester, you can attest before the October 1 deadline. So if you attest before October 1, 2017, you won't be penalized for 2018. And because MIPS is starting in 2019, we're not sure what's going to happen in 2019. I would assume you would get credit for meaningful use based on MIPS because meaningful use is part of that.
What is MIPS?
MIPS stands for the Medicare Incentive Payment System. That's going to be part of the MACRA program that's coming. And 2018 requires a full year of reporting. State flexibility hasn't changed, and they're looking at only electronic documents except for e-prescribing. Except for patient education materials. Patient education materials can still be provided on paper, and you can get credit for it through stage 1 and stage 2. However, once you go to stage 3, patient education materials need to be supplied electronically. So, there's a question. If we attested to MU2 90 days in 2014, are we still supposed to attest 90 days in 2015? Is that correct? In 2015, yes, it's 90 days. It's 90 days for everybody when you're attesting for the 2015 year. If we cannot attest before January for Medicare, how are we supposed to submit our Medicaid by December 31st? This is for the hospital. That question I may need to get back to you on, because the Medicaid would be a state requirement, and I believe you would need to check with your state to see if you're attesting Medicaid only. But if you're a hospital, you're going to be on the same calendar year within your state as well, so I would assume they would have their deadline as February 28th, but you're going to have to check with your state. That's going to differ state by state. This state, they are moving the deadline back in Minnesota. So the proposed program goals and objectives are up here on the screen. They actually differ in order between stages 1, 2, and stage 3. I believe this order is actually the stage 3 order that came out in the proposed rule. So it's actually somewhat different. But they're all pretty much covered in stages 1, 2, and 3. So this screen gives you a summary of where stage 1 stands between 2015 and 2017. These are the types of things that we're going to go into detail on next week, so I'm just going to touch base on this on a high level. Security risk analysis for stage 1, regardless of year, is unchanged. Clinical decision support. In 2016, you'll need to have 5 rules. And in 2017. So if it's yellow, that means it's new and more. If it's green, that means it's less. Drug interactions, again, that's part of your meaningful use, and actually it becomes incorporated into, drug interactions are yes or no. Medications, on your medication list, again, it is core. This is computerized provider order entry. Computerized provider order entry of medications, 30%, and it increases for stage 1 to 60% in 2016 next year, and it stays 60%. CPOE for labs and CPOE for radiology. There was no requirement to do that in 2014. They're giving you an exclusion to do it in 2015. And you may take it as an exclusion in 2016 as well. But by 2017, even if you were supposed to be at stage 1, you will still need to do CPOE for labs and radiology. The question is, do hospitals and EPs have the same set of measures for 2015? For the most part. You'll see here, if you look on the screen, you'll see e-prescribing has EP in parentheses, that means eligible professional. If you look for ERX with formulary, EH, that's eligible hospital. And there's the question, the testing for 2015, you use 90 days in that calendar year or for 2014. If you're testing for the 2015 calendar year as a professional, your 90-day reporting period needs to be in the calendar year of 2015. If you're attesting as a hospital, your 2015 calendar year can be October 1, 2014 through December 31st, 2015. And Minnesota, for those of you who cannot see, Minnesota has extended the grace period for testing to meaningful use for the hospitals and professionals. So for payment year 2015. So going back to the chart, the next one was e-prescribing for eligible professionals. That increases for eligible professionals to 50% in 2016. For eligible hospitals, there's actually e-prescribing with formulary. And what they had said was that they had thought hospitals were going to need to start doing that in 2016. In the proposed rule and the final rule, they're excluding that. So hospitals will not have to do e-prescribing on discharge from the hospital or the emergency room, but they will need to do it in 2017 at 10%. Drug formulary for the professionals was a menu item. It can be excluded in 2015, but in stage 1, 2016, it's going to be part of the e-prescribing measure, period. Summary of care, any method. In other words, if you send a paper summary of care, that's no longer measured. It was a menu item in 2014, and because it's now an electronic version, it was not required for stage 1 folks. It's not going to be required at all in 2015, but the summary of care record electronic, which is the next one, the stage 1 folks can claim an exclusion in 2015 because it was not part of the plan for 2015, but it will become a stage 1 measure in 2016. So the requirement is 10% in 2016, and we'll go into details later on. There was a question, I thought everyone was now in a modified stage 2 for stage 1 and for stage 1, it would be a modified stage 2. That is correct. It's a modified stage 2 with exceptions, and the exceptions are for those people who would have been at a stage 1 and who would have been at a stage 1. So, let's see. Next one is patient education materials. That was a menu item for stage 1. It's now an exclusion. You can claim if you didn't plan on doing it. Then it becomes a core item at 10%. Medication reconciliation, again, because it was a menu item, you can claim an exclusion, but it becomes a core item at 50% in 2016. Have access to view, download, and transmit your information. That was a core item. It's going to remain a core item for stage 1. The actual fact that patients view, download, and transmit their information, it's an exclusion for 2015. They have said for 2016 for stage 1 or any stage, it's just one patient. But also new in the final rule, they said 5% starting in 2017. So they're gradually ramping up to what it will be in stage 3. A secure messaging, excluded for 2015 because it hadn't been planned on at all, but it will be a requirement in 2016 for one patient, and it'll also be 5% in 2017. The other change about secure messages, as opposed to a secure message from a patient to a provider, it can now be a secure message. It is now, starting in 2016, a secure message from a provider to a patient. So that removes the patient activity out of the barrier. Immunization registry, that's pretty much unchanged. Syndromic surveillance. Specialized registries weren't available for stage 1, and reportable labs were a menu item for hospitals. So each of those now, for those who would have been in stage 1, they would need to do 1 of 3 in 2015 if you're a professional, or 2 of 4 if you're a hospital. And if you're in 2016, it increases to 2 of 3 and 3 of 4. That's stage 1. Now, stage 1 just has some exceptions, as we mentioned, but it virtually is stage 2, and the exceptions are basically the things that appear on the screen in a pale green. These are the elements that were actually eliminated from what used to be required in stage 1, and you can see the list up here. In the columns on the right, it indicates where they would appear, since they're not specifically measured as individual measures, where they would appear as part of a bigger measure. So, for example, the first 6 appear in electronic access to health information. Let's talk about stage 2. For those folks who are in stage 2, there is not that much change with the proposed even to the final rule. We do see one very significant change, and that's for eligible hospitals. They were concerned about the fact about having to do e-prescribing on discharge from the hospital and discharge from the emergency room because they didn't have it in place. And if it started by January 1 of 2016, that would have been crazy. So they actually have given hospitals an exclusion for that in 2015, and you can continue to have an exclusion for it in 2016 because they assume you really could not get it in place in that short a period of time. So hospitals have the exclusion for both of those years. The other significant changes in the final rule is that patients who actually view, download, and transmit, they've made it one patient for 2015, one patient for 2016, and they've reduced it to 5% for 2017. For secure messages, again, now they're secure messages from the provider to patient. For 2015, you just have to say it's enabled. For 2016, that you've had an interaction with one patient, and 2017, 5% of your patients. And you can see the changes in immunization, syndromic surveillance, specialized registries, and reportable labs. Again, specialized registries were EP only in 2014, so they did not involve a hospital, but they're actually allowing hospitals to be a part of specialized registries starting in 2015. Now, you may say, okay, so if hospitals have to pick 2 out of 4, that means that reduces their numbers because they weren't planning on doing specialized registries, but there were a couple that had been required in previous years. So, for example, both reportable labs and immunization registry had been required in previous years, so they would just need, as was syndromic surveillance. So it really doesn't create a challenge for them, so they would have already been reporting 3 out of 4. So those are the changes for stage 2, really much simpler. I'm going to talk about what qualifies as exclusion for public health. I'll get into the details on that next week. And what does C and M stand for on the left side of the screen? C stands for, it was a core measure that year, and it was a menu item. Could you please clarify secure messages to patients for 2015? That's essentially, it's a clinical message from the provider to the patient, or a clinical response from the provider to the patient from a patient-initiated message. Again, we'll go into the detail on that next week. If a person only gets a flu vaccine in the clinic, are they considered a patient? They probably did not see a provider, so they would not be considered a patient. And I think that answers the ones that are pending. So again, these are the ones that have been deleted from stage 2. I won't get into the wisdom of it, but again, they deleted it because they said they would either topped out or redundant. And the ones can be called redundant. You'll see in the second and third columns where they may actually appear. But if you look, there's some that are actually not measured specifically. For example, family history is not measured, advanced directives is not measured, and EMR within the hospital is also not specifically measured to the best of my knowledge. I could not see it anywhere in the rules. What we'll also notice is the second, third, and fourth one up here. These were proposed for stage 2 in the proposed rule for stage 1 and 2, and they were actually omitted in the final rule. Case reporting is not included, so that's dropped because they said it wasn't mature enough. Public health registry and clinical data registry were actually combined into specialized registry, so they're not called out specifically. So that's why those things which were not required in stage 2 are actually showing up on the graph now for stage 2 on the previous slide. So moving on, just a summary of some of the changes from stage 3 from what was in the proposed rule. E-prescribing was supposed to be at 80%. They actually decreased that to 60%. Computerized provider order entry meds were supposed to be 80%. They also decreased that to 60%. Enabling view, download, and transmit for the exchange element or application programming interface, or API access, was now changed to VDT and API access, so those both need to be enabled within the EHR. And they changed patients using VDT or API access from 25% to 10%. They also clarified it because it wasn't clear whether if you, say, had 20% of your patients using VDT and 20% using an API, would you fail because neither of them was 25%? And they clarified it would be a combined number. So rather than viewing the ADT and API as being separate elements, they're considering it as patients actually retrieving their health information. So that would go from 25% to 10%. As I mentioned, secure messaging is now to the patient, and incorporating patient data is from 15% down to 5%. So let's go over some of the specifics. So for stage 3 in 2017, we see that, well, let's start from the top. Security risk analysis, really no change. There's some changes in the verbiage, but otherwise no change. Clinical decision support is the same. Drug interactions are the same. And medications are the same. Labs are now 60%. Radiology is 60% from 30%. And e-prescribing has gone from 50% to 60% in 2017, and they stay that way. And again, for those attempting to do stage 3 in 2017, it is really only a 90-day reporting period. E-prescribing with drug formulary for professionals, really it's a part of the e-prescribing rule. For the hospitals, it goes from stage 2, 10% in 2017 to 25% and stays there. Patient education materials goes from 10% in 2017 to 10% in 2017, stage 2, to 35% stage 3 in 2017. And again, that 35% paper does not count when you're at stage 3. It has to be available electronically and unique to that patient. So there is a question. If we are successfully attesting to MU2 in 2014, what are we attesting to in 2015? If MU2 was your first attestation year in 2014, you're attesting to MU2 in 2015, and you're just attesting for 90 days. So, have access to view, download, and transmit. Again, in the way that it's changed between stage 2, 2017, and stage 3 is, number one, the number has increased from 50% to 80%, and they're also required that the application programming interface be turned on and be active. So more changes for stage 2 to stage 3 for 2017. Oh, did I not? Let's see here. I suppose I'm redundant here. Let's start. We actually, let's see, I didn't cut off the ones I was supposed to cut off, and I just jumped to the wrong slide. Let's see, have access to VDT. Okay, security risk analysis is redundant, and that's the one that's redundant on this slide. That's what threw me off. The second one, actually view, download, and transmit. It was a core item in 2017 at 5%. Now, it remains 5% for stage 3 in 2017, but it increases to 10% for stage 3 in 2018. Secure messaging was 5% in 2017, or is 5% for stage 2 in 2017. It remains 5% in stage 3 in 2017 and increases to 25% in stage 3 in 2018. And again, it can be provider-to-patient communications. And lastly, the requirement to be able to incorporate patient-generated data, such from specific devices, into your EHR. That's a new one. That would be for 5% of the patients in 2017 and 5% in 2018. Now, there are 3 measures in here. You need to report all 3 of the measures within this group. That's why in that column it says attest, all, meet 2. So you'd have to meet the threshold on 2 out of 3 of those measures. So, for example, if you're having trouble incorporating patient-generated data, but you're able to patients were view downloading and transmitting their information, and were doing secure messaging, both above 5%, you will have made this, but you would still need to report your percentage on patient-generated data, even if the percentage was 0, and you would still be able to attest that you were a meaningful user. The second group are also a group of 3. The electronic summary of care, sending that, incorporating a CCDA from another provider for new patients or patients where the information is provided to you or available, and clinical information reconciliation. 2 of those are new. The incorporate CCDA and the clinical information reconciliation are new. Electronic summary of care was 10%. Now they're going to say, if you're going to do stage 3 in 2017, it's going to increase that to 50%, and it's going to stay 50% in 2018. And for incorporate CCDA, that is a new one. It's going to be 40% is the threshold, and will stay that threshold in 2018. And clinical information reconciliation is 80%. With keeping an 80% threshold. Now, I have a question. Regarding secure messages, does it have to be sent through the EHR only? Yes. You have to use the certified technology within the EHR to send the message, and the technical specs are actually spelled out on the documentation on the CMS website. We'll go into greater detail on potential ways you could achieve this when we talk about this next week. So again, with these summary of care incorporate CCDA and clinical information reconciliation, you need to meet 2 of the thresholds on that, but you have to report all 3. And again, for stage 3 in 2017, it's only 90 days. For stage 3 in 2018, it's going to be a full year. Now, I'll just take a break here and mention this. This final rule is a final rule with comments. There's been a lot of confusion about what they meant when they said with comments, because typically when you see a proposed rule, there are a lot of questions within the proposed rule where they actually elicit comments. The only place that they're eliciting comments really is some general comments on the stage 3 requirements. So it's not going to change anything in this final rule. It's probably going to potentially affect some future rulemaking if there is for stage 3. Again, because that macro rule came out right after this proposed rule came out, so there may be some potential changes going forward. But it really only is a focus around stage 3. So, for example, if there's specific issues on some of these, I would probably be wise to be able to use the comment period to reply to it. So medication reconciliation, which is a core item at 50% in 2017, is now being incorporated into the clinical information reconciliation. Now again, that methodology can be when the information comes electronically from another record, or it can be basically reviewing the medication list, the allergy list, and the problem list with the patient when you're with them in the room. So it doesn't have to necessarily be electronically done. It's just that you've reviewed it and made sure it's accurate. And again, now we've got the final four of the immunization registries, syndromic surveillance, specialized registries, and reportable labs. Those for stage 2 in 2017 are being modified, so if you want to do stage 3 in 2017, you'll only have to do 2 out of 5. Now, in the proposed rule, they had said 3 out of 5, but in the final rule now they're just saying 2 out of 5 for professionals, but they're still saying 4 out of 6 for hospitals. So we have immunization registry, we're familiar with that one. Syndromic surveillance, we're familiar with that. The specialized registries for stage 3 are actually will be split into public health registries and clinical data registries. And both of those you can report on more than once. So you can do, say, 2 public health registries or 2 data registries. And reportable labs is strictly a hospital measure, and that has really not changed. Now, there's a question. Medication reconciliation is applicable only if a patient is transferred to another doctor. That is actually true if it's a referral. That is actually true if it is a referral or a new patient, or in some instances, any particular transfer of care. So again, if it's a hospital receiving a patient, that would occur at that time. There are exclusions, and there are exclusions for many of these. The less than 100 occur during the measurement period. Those still stand, and we'll go into the details of those next week. Incidentally, they did not reduce the number of 100 for a 90-day measurement period. So if you have less than 100 in a 90-day measurement period, or for those years when you have a full year measurement period, it's still less than 100 for an exclusion. Again, we'll go into details on those next week. What is the rule for deciding whether to attest to stage 2 or stage 3 in 2017? It is your choice. You can only attest to stage 3 if you have 2015 certified software, and or if you have the equipment of the certified software that's required in order to be able to attest for the rules for 2017. So, for example, if you want to attest towards immunization registry, submitting to an immunization registry, the stage 3 rule for that is actually bidirectional and not unidirectional. It is unidirectional for stages 1 and stage 2. That was changed, so people don't have to worry about the bidirectional. But if you're going to do stage 3, it would be bidirectional. So since 2014 certified software is not capable of doing bidirectional and not capable of getting predictions, you wouldn't be able to do that particular measure with 2014 certified software. Therefore, you'd have to attest to stage 2 in 2017. You can only attest to stage 3 if your software is certified to attest to all the things to which you need to attest. And then you only do it if you wish to. Okay. So moving on. We just talked about that. In 2014 or in 2015, you can use 2014 or 2015 certified EHR technology or a combination through 2017 for attesting to meaningful use 1 and 2. But if you're going to attest to meaningful use 3, you need to have certified EHR software in place. So there are no changes in the clinical quality measure reporting for 2015 through 2018. This is 2017 there, but it's actually 2018. Of note, however, in the italics you can see it's still a full year reporting in 2017, even if you're just a first year meaningful user reporting for only 90 days. And under Medicare, it will still need to be a full year of reporting. And let's see. So that really completes the formal presentation. What I'd like to do at this point is open the line for questions. I'll answer all the questions that I can. Those I cannot, I will look up and find the answers to for our next call next week, which is on the Wednesday, not on Monday, but on Wednesday. And you can submit your questions either verbally, there's a process that we'll introduce you to in a moment, or you can continue to ask your questions as you have before in the chat, and I will answer them as we get them. Again, if you wish to ask your questions privately, do send your questions to the panelists, and that way you can ask a question and not expose any ignorance to your colleagues on the line.
Yes.
All right? So with this, I'll hand it over to Candy. Oh, I do have a question. And so the CQMs do not have to be the same 90-day reporting period as the measure. That is correct. The CQMs do not have to be the same 90-day reporting period as the measure. So I will mention, I guess I'll mention this myself since the slide is up. LSQN does provide meaningful use consultation services for stages 2 and 3. We provide education on meaningful use and what it means, the ins and outs, the good, the bad, and the ugly. We provide technical assistance on how you can actually make it work. We have learning in action networks where you can actually talk to and work with each other to improve your care, not just around meaningful use, but also around effective use of your EHR, and all this service is supported by CMS, so it's provided to you free of charge. And on the next slide, you have your contact folks from each of your respective states. So while you open the lines, I see a couple of questions have come in, so why don't you go through the process of telling folks what to do to open our lines, and I will then read the questions I've gotten so far.
The floor is now open for questions. If you do have a question, please press the number 7 on your telephone keypad. Again, that's the number 7 to ask a question.
So one of the questions that came in, it was tied to a previous one. They attested to stage 2 in 2014. And actually, regardless whether you attested to stage 1 or stage 2 in 2014, that was giving you a grace period to actually do stage 1 in 2014. If you'll see on, I'm going to try it. Oh, I can't actually do it that way. I'm going to go back to slide number 3, I believe it is. See if I can get there. You'll see, the asterisk is not on this page. But for those folks, here's the asterisk right here. For those who were supposed to do stage 2 in 2014, even though they did stage 1 in 2014 because their EHR was not ready, they're still considered to be stage 2. So they would still be required to do a full year. Well, in 2015, they'd only need to use 90 days anyway because it's just 90 days in 2015. So I take that back. It really makes no difference for you. And with this year, you still need to do a full year. So it really makes absolutely no difference on that whatsoever. Okay. Let's see if I can go back to all the way back to the end. So we have the contact. So I've got some questions here. We did claim exclusion last year for medical reconciliation when we attested to stage 2, 90 days, as there was no transfer of patients to another setup. So does that same rule apply to us in year 2015 when we attest a 90-day period? If you have less than 100 in your 90-day period, yes, you would still have that exclusion. So again, we'll go into those details next week. But that is true. There are exclusions based upon the number. So you would have that exclusion for it. That has not changed. For EPs that practice in multiple locations equipped with CHRT, how might their combining of reports change under modification S2 and S3. In S2, EPs report on menu measures from a coordination of locations that equals greater than 50% of encounters. With the removal of the concept of core menu, do you see any changes coming for providers needing to combine MU reports? I'm going to look into that one, and I will address that one more directly next week. I recall something was talked about that within the final rule, but I do not believe anything has changed. I will say, and it may be related to this, but it may not be, I will say that in this final rule, if you are going to claim something as a menu item, you don't need to prove that in the event of an audit. You can exclude it, and you don't need to retain proof of that fact. So I'm not sure if that has bearing on that, but I will look into this question and will provide an answer to that later. Okay, going on. 2 specific questions. You can answer next week. 1, a practice with both nephrologists and endocrinologists using a nephrology registry. Can this registry count for the endocrinologist too? I will look into it specifically, but my understanding based on the rule is that they're keeping it very general, and if they're both using that registry, it would count for both of them. They're being very open-ended about how they define registries. 2, for an ENT specialist who only receives referrals, would the transition of care measure of 10% electronically being reported be for them, or would they be excluded? Technically, it is a transfer of care, but there is a challenge using direct mail. Thank you. I'm going to need to look into that one specifically as well, because they're receiving information, but then when they send the patient back, they would need to send the information back to the other provider, and that percentage may be a barrier for them. I would agree, but I'll look into that more specifically. These questions are great. I love the way you make me not look good, but this is what this is all about. Okay. Some of our S1 EPs will likely meet the modified 2 requirements and therefore may not need to claim an exclusion as allowed for Stage 1 EPs. Do you know if that will be an option for Stage 1 EPs during the attestation process? I imagine during the attestation process, if the exclusion is something that they're allowed to take, I imagine they would be able to claim it if they wish. They could put their percentages in, but I cannot really say for sure. We will not know for sure until the attestation website is up and running. But again, because they don't need to prove the fact that they're planning to exclude something, they're actually in fairly good shape if they exclude something because they say they had not planned on doing it. Do you know if Epic Care Everywhere counts for the transition of care measure? That's something you're going to need to ask your vendor, because it really depends upon the specifications. But again, it has to be sent. My first impression is no, but you're going to need to check with your vendor. All right. Somebody is complimenting me. I appreciate that. That's very nice. I missed what number? Oh, there's one that I missed on chat apparently. Give an example of patient-generated data. Scales at the patient's home that are Bluetooth and send information into the portal. Fitbit items, for example. Blood glucose monitoring that the patient is doing at home. Any elements like that. Where I'm generating information that goes to the provider. Now, I recognize that could create a steady stream of information that could potentially overwhelm providers. So we've made it aware that there's going to need to be some intelligence or some process to be able to filter through that information so valuable information will be caught and not buried within information that is really not valuable. So it's like getting a data dump of 80,000 blood pressures that were taken in the ICU when you get your patient back. How useful is that really? Okay, do we have any questions? Any questions queued up?
There are no questions in the queue at this time.
Okay. All right. If you have questions that you want to ask verbally, ask away. Otherwise, continue to ask your questions on the chat, I think. Okay, for the summary of care objective, we're having an issue with direct addresses for external EPs, those who we will transition patients out of care to, not being in our EHR's directory. If an external provider isn't listed in our direct directory and we are unable to send the CCDA to them, will this count against the EP? Or is the EP mandated to discover the receiving EP's direct address and build it into their EHR? I would say the latter. I mean, that is a problem. I agree, that is a problem. But we're going to need to come with a solution. Now, there is the possibility that it could be sent to Health Information Exchange or someplace like that, but you still need to have proof that it was received by the individual to whom that summary of care is directed. So just sending it to the HIE is not going to count. The HIE has to document the fact that it was actually received by that provider. So that does create a problem. These are great questions. Keep them coming.
Again, if you have a question on the line, please press the number 7 on your telephone keypad.
I'm looking to see if I've missed anything. If I've missed any questions, could you please copy your question and resubmit it? Because there's a pretty long slew here, and I want to make sure that I get all of your questions here. So while we're waiting, I'm going to scroll back up on some of the slides and see if there any other things come to mind that I may want to mention just for your information. Yeah, with this, again, with labs, meds, and radiology for the 90-day reporting periods for stage 2, again, it's still just going to be, if you do less than 100, you can exclude them, which I think is pretty generous. We will be making these slides available again. These tables I find are valuable. If I find errors in these tables, we will make sure to update them as time goes on. I have made many revisions of this over time as I've looked through these tables and put these presentations together. Next question. If a provider cannot send an electronic summary of care to a facility because they do not have an EHR, that would count against the provider. Is that if they send over 100 referrals, there is no exclusion, correct? That is correct. That's why it's 10% or whatever percent it is. So if you send less than 100, you would have an exclusion, and otherwise you would need to do the percentage as specified. Do dental and x-rays count as radiology orders? Well, for dentists, they would, yes, I would imagine. But I can't say for sure, so I'll look into that one. That's a good question. Notice they no longer have to be available within the EHR. That has been dropped. And I should mention for stage 3, which I did not, is that they're actually expanding it to imaging and not just radiology for stage 3. So I thought that would be something to be aware of, is that stage 3 is imaging and not just radiology. Planning to do AIU for a new provider for 2015 for Medicaid. Is this still fine? Yes, that is still that's still fine. Again, I would mention that that person, if they have any Medicare patients or bill at all under Medicare, they'll be penalized in 2016 and 2017 for not being a meaningful user for 2015. So if they can, I would recommend that they attest for calendar year 2015. So what do you feel are the top 2 or 3 challenges for providers by 2015 for 2015 attesting? That's a good question. I'm not sure if you mean professionals or hospitals, so I'm going to ask you to resubmit and tell me if that's professionals or hospitals, because I'm going to go on to some of the other ones I have down here. We attest to Medicaid. Did I see that we can also attest to Medicare to stop the penalty? Yes. Well, if you attested to Medicaid and you had the 20 or 30%, you don't need to attest to Medicare as well. It's only for those instances where your percentage of Medicaid patients dips below the threshold where you can't attest to Medicaid. So you may need to use the Medicare attestation site in order to be able to avoid the Medicare penalty without actually being switched into the Medicare program, because Medicaid payments go on for years later and they don't have to be consecutive. For stage 2, what objectives have less than 100 patients exclusions more than mentioned? Yes, there are more than mentioned, and I'll go into the details on that next year. So for EPs, what do we see are the ones that will be challenging? Let me go back up here and see if I can pick some. For EPs in stage 1, I think I don't think e-prescribing is going to be a challenge. Again, that's yes or no. Summary of care, the electronic summary of care for 2016, that's going to need to be in place. And I don't think that'll be a challenge because you're already using the EHR and you already have something like a portal, because people have to have the ability to view down and transmit. The fact that one patient does it is not a challenge. So I think for stage 1, it really is not going to be, I don't think there's going to be that much of a challenge. And for stage 2, I think some of the more significant ones, I think, again, those are addressed too. There's nothing new and ugly here that I can see that's coming. Again, in 2017, your numbers for e-prescribing with the formulary is going to be 10% in 2017. And, you can't see my pointer, I forgot about that. And to actually view, download, and transmit, again, that becomes 5%, and the immunization registry becomes 5%. For stage 2, I don't see that being an issue. I think some of the more significant ones are going to be some of the stage 3 ones in 2018. And I think I've already mentioned those, the ones that be incorporating the CCDA, clinical information reconciliation. I think those are going to be challenging if you're going to be using the EHR to do it, because if you're getting problem lists, medication lists from all these different providers, to try and merge it into one unified record, I think is going to be a pretty significant challenge. Secure messaging, to include the patients in the secure messaging, I don't think is going to be a challenge. Maybe by 2018 at 25%, that may be a bit of a challenge. So we're about ending here, so the last question I have here is, I understand that 2016 will be the last year to start NU for EPs in Medicaid and be eligible for all incentive payments. Is that correct? Yes, that is correct. And with that, I'm going to hand it over to Jerry, who's going to close us out here, if I can get this arrow key to work. Okay, Jerry.
And I just wanted to make sure we didn't have any other questions on the line before we close for the day.
There are no questions in the queue at this time.
Thank you. And thank you, everyone, and Dr. Kleeberg for your presentation, and everyone for joining us. Just wanted to remind everyone again that we will have a follow-up webinar next Wednesday, October 28th, beginning at 11:30 a.m. Central Time, 12:30 p.m. Eastern Time. Thank you, everyone, and have a great day.
This concludes today's teleconference. You may now disconnect.